Okay, guys, let's finish up what we didn't get to in class today. This is chapter 28, Obsessive Compulsive Disorders. All right, so it breaks down into two things, obsessions and compulsions. So the obsessions are like the thoughts, excessive, unwanted, intrusive thoughts. Compulsions are actually carrying it out. Okay, so ritualistically touching something, that's the compulsion. Sorry, my clicker's not working. Many times this begins in childhood, kind of like the other disorders we talked about today, bipolar and whatnot. But many receive treatment only after the disorder has significantly affected their lives. So a lot of times they're not diagnosed until later. In preschool kids, a lot of times this presents and it looks like separation anxiety. Dissociative absorption, that's a tendency to become excessively absorbed in fantasy, like movies or online gaming, leading to decreased self awareness and inattention to their surroundings. I think that's becoming a lot more common today with kids who play video games. So you might be seeing that, and that's called dissociative absorption. My clicker keeps going to the wrong screen. I apologize. Diagnostic criteria, obviously, they have to have the presence of obsession and compulsions. They realize that their thoughts and actions are unreasonable or excessive. They're not a result of another disorder, and they're not a result of the presence or of a substance or medical condition. So really, to diagnose this, we're ruling a lot of other things out to come to this conclusion. Across the lifespan, so for kids, I already mentioned it may go unnoticed. Often they have another mental disorder as well. The book gave some examples of what kids will do if they have obsessive compulsive disorder. One of the examples was touching every third tree. Another was avoiding the cracks in the sidewalk. We've all done that, right? Don't step on a crack because you'll break your mama's back. Or consistently verbalizing fears of losing a parent in an accident. So that one's a little bit different. But those can all be underlying, symptoms of OCD. Interesting fact that I read in your book, there is a link between streptococci and other infections. They've had them before OCD appears, which I find fascinating that can happen. So that they may have had some type of a strep infection, and that triggers the OCD to start. There are also studies, and this doesn't have to do with mental health, that I don't know if it's strep, or for some reason I want to say it's mumps. Kids who have had that and all of a sudden 6 months later get type 1 diabetes. So it's interesting how those viruses can attack our bodies and cause a switch in something. Lifetime prevalence is 2.3%. So that's kind of in the middle of what we were talking about. I think we said for bipolar 1 to 4%. So 2.3. We already talked about the age of onset. For ethnic, there's no major differences. But however, like with any other cultural issues, we need to just be aware of how their culture accepts it and how they deal with it. Some individuals may end up having depression or anxiety now that they have OCD because their culture doesn't really accept it. It's important to talk about the family response to the disorder. So this can cause some distress on families. It can cause caregiving burdens on families. So those are all things that we need to keep in mind. We've talked about that with the other disorders as well. So what are we going to do for these individuals? You can actually do ECT for OCD. However, according to your book, the jury's kind of still out on this. Sometimes they've seen some help and other times they haven't. It's really inconclusive as far as ECT goes. The TMS, it's non-invasive. This is where you use magnets to stimulate brain cells. Psychosurgery, this is kind of an extreme option, I guess you could say. But after OCD, extreme OCD after drugs or behavioral therapy. So surgery is an option. Safety issues, what do we worry about? Did you say suicide? Because that is correct. Evidence-based nursing care. Again, this is all going in the same order as every other disorder that we've talked about. Physical health. So we're not going to really talk as much about like sleep and nutrition here, but what we worry about for these guys is their skin. So a lot of times people who have OCD will have excessive hand washing, bathing, cleaning. So you want to look for lesions created by excessive repetitive motions. For nutrition, you worry about an eating disorder that happens in about 17% of people with OCD. A variety of medications can cause symptoms in addition to over the counter. So those medications, I'm sorry, back that up. I spelled something wrong and I spoke wrong. There's a variety of medication to treat the symptoms, and there's also over the counter medications to treat the symptoms. Substance abuse, about a third of individuals with OCD have substance abuse. Psychosocial assessment, so we're looking at their mental status. We kind of already talked about their appearance, what they might look like, where they might have lesions. I'm going to guess their self-concept's not going to be great. They're probably pretty self-conscious about all these repetitive actions that they're doing. They probably don't want to go out in public because of it. So that's something to be aware of. Stress and coping patterns. How do they cope? What can we find a positive coping pattern to help these individuals? And then how's their social network and their support system? Again, it's really important that we have a therapeutic relationship with this patient, establish trust so we can work towards recovery and wellness. I have the psychosocial assessment on there again. That was already on the last page. And it's here again. I apologize. Again, maintaining skin integrity is a big issue. I want to talk about relaxation techniques with them and medication interventions. SSRIs here again are the number one drug of choice. The few I wrote down were fluoxetine, paroxetine, and they're typically used with cognitive behavioral therapy. So it's not just medication, it's not just therapy, it's both. So other nursing interventions that are crucial, we want to reinforce the cognitive behavioral therapy. We talked about relaxation techniques, mindfulness, which the lady from EIU talked about when she came. Cue cards can help with excessive thinking as well. The exposure and response prevention is kind of what we talked about with bipolar disorder, where the person is exposed to situations or objects that are a known trigger to induce anxiety, but is asked to refrain from performing the ritual. The goal is to help the individual understand that resisting the ritual is less anxiety producing and time consuming than performing the rituals. I'm going to repeat that one more time because that is very important. The goal of exposure and response prevention is where they're repeatedly, introduced to whatever makes them do the activity over and over again. The goal of that is to help the individual understand that resisting the ritual is less anxiety producing and time consuming than performing rituals. Okay? So that's what we're trying to get them. Different behavioral interventions and interactions. So routines, getting them into a routine. Initially, we are going to allow rituals, but then we're going to try to back off on that. Encourage discussion, identify triggers, what's triggering them to constantly perform those rituals. Those are all things that we're going to look at. We already talked about mindfulness. I feel like that's another repeat I've got going here. Psychoeducation. Really, we're going to talk about stress management. We're going to talk about relaxation and anxiety reduction. And then obviously provide family education as well. We want them to be on the same page. Typically, these individuals you're not going to see in the emergency department. These rituals and OCD is not something that's going to cause them to come into the ER for emergency care. These guys are typically treated outpatient. The only time it would be an emergency is if there's a suicide risk. Virtual mental health care, we've talked about this several times. They can talk with a psychiatrist on Zoom to help them. They can have tele-support groups. We've talked about the cognitive behavioral therapy. They've done those online and they've done them in person. And then there's also a lot of different emerging technologies. We do want to integrate with primary care because that is where they typically are treated, is in outpatient care. There's some other obsessive compulsive disorders that your book talks about. I'm not sure that you want me to try to pronounce that first one. Trichotillomania. I think that was pretty good, honestly. This is hair pulling, self-destructive hair pulling disorder. Excoriation disorder, so skin picking. Sometimes we see this in meth addicts. Body dysmorphic disorder. And really what I put on this slide is what is in the book. There's not a lot in the book about these disorders. Hoarding disorder. I would love to have an in-class discussion about this. There's lots of TV shows about hoarders and whatnot. But difficulty parting or discarding possessions, 2 to 6% prevalence. Can start in childhood. I feel like one of my kids may have this. I definitely do not. I'm a tosser. I throw everything away as soon as I can. There is cognitive behavioral therapy and medication for these co-occurring disorders. All right, that's it. I knew it wouldn't take long to get through there. Again, when you go through these chapters, please outline. They're all the same. They're all outlined the same. Pay attention to that and really try to understand what's different with each disorder. A lot of times we're assessing for the same symptoms, but what's different? We're all worried about suicide with them, but is there also something else like injury we talked about with bipolar disorder that could be different? So when you're looking at each disorder, try to find out what's different in all of these areas and what really sets that disorder apart. So, guys, week 5, it's done. On to the next.